Good evening, everyone. I am currently pursuing postgraduate in pediatrics from Government Medical College from South. So I always had the dream of learning new things and making people learn new things, the vice versa. So today I am going to start from the series of common viral exanthems which we come across in the day-to-day life in the pediatrics department. So the first viral infection which I am going to start today is on measles. So measles is the common and serious exanthematous illness which still usually is causing annual deaths in the developing countries. Coming to the etiopathogenesis, it is caused by the RNA virus belonging to the group of paramyxovirus family, and this measles is transmitted by the droplet infection which spreads from the secretions of the nose and throat of the affected individual to the susceptible contacts, usually 4 days before to 5 days after the rash. The secondary attack rate of the measles is 90%. As we all know, what is secondary attack rate? It is the rate from which it is transmitted from the affected individual to the susceptible contact, which is very high. It is highly contagious, so it is very high in the measles. It is usually of 90%, and the main portal of entry of the measles is respiratory tract, where the virus multiplies in the respiratory epithelium. It is usually the primary viremia which occurs in the infection of the respiratory reticuloendothelial system, followed by the secondary viremia. Usually it is seen as systemic symptoms. So the incubation period of the measles is 10 days. The main clinical features what we see in the measles is it is most commonly seen in the preschool children, and infants are protected by the transplacental antibodies which generally disappear by 9 months. So we give the measles vaccine at 9 months. Hence the rationale for vaccination at this age is due to this, because the protection to the infants is through transplacental antibodies which are transmitted from the mother to the infants up to 9 months. So the clinical features we can see in the two phases. First is the prodromal phase. In the prodromal phase, what we see is fever, rhinorrhea, conjunctival congestion and dry hacking cough. These are the features what we see in the prodromal phase. And the Koplik spots, which are considered as pathognomic of the measles, they appear opposite the lower second molars on the buccal mucosa on the second to third day of illness as grey or white lesions resembling sandpaper, resembling grains of sands with surrounding erythema. This rash usually appears on 4th day with rising fever, appears as with rising fever. So this you guys remember, when the rash usually appears on the 4th day, it also causes the rising temperature, rising fever. So this rash appears as faint reddish macules behind the ears, along the hairline and on posterior aspects of the cheeks, which rapidly becomes maculopapular and spreads to face, neck. In the descending order, it spreads to the face, neck, chest, arms, trunk, thighs and legs. So this rash, it mainly starts from the center, that is it starts behind the ears and then it spreads peripherally. So it is known as centrifugal rash, which is different, which we can differentiate it from chickenpox rash, which is mostly centripetal in nature. So this rash, it also disappears in the same form like how it appeared, like it appeared from behind the ears, neck, chest, arms, trunk, thighs and legs. So it also disappears in the same way over the next 2 to 3 days. It then starts fading in the same order, leaving behind briny desquamation and brownish discoloration which fade over 10 days. So we come across two other terms in this measles. One is modified measles, which is usually seen in the children who have been passively immunized with the immunoglobulin after exposure to the disease. So when the susceptible contacts comes in, susceptible means who the person gets exposed to the diseased individual. These contacts are immunized with the immunoglobulin after exposure to the disease. So this is usually develops in the children who have been passively immunized with this immunoglobulin. The incubation period in this is it is prolonged to 21 days. In the modified measles, the illness is similar to the measles, ordinary measles, but it is milder disease. The prodromal period of 1 to 2 days, what we saw in the typical measles is like low grade fever, coryza, congestion. These all will be minimal or absent. There will be no Koplik spots which are pathognomic of the ordinary measles, and here the rash is also sparse and discrete. And the another term which we see is atypical measles. This is usually rare and it is usually usually seen in the individuals who were previously immunized with the killed measles vaccine. Usually what is the measles vaccine is live attenuated vaccine, but the people between 1963 and 1967 have received the killed measles vaccine. So they have developed this type of measles, that is atypical measles, in which the rash starts from the hands and legs. Usually what we saw is central to peripheral, but here the rash starts from hands and legs and then it spreads centrally. Next, rash is most prominent in this atypical measles. It is most prominent in the body creases, and here the rash what we saw in the ordinary measles is maculopapular, but here it can be macular or hemorrhagic vesicles, petechial or urticarial. And the another term is hemorrhagic measles. Here it is characterized by the purpuric rash, and it is also bleeding from the nose, mouth or bowel. Next, coming to the complications, what are the most common complications we see in the measles is otitis media and bacterial bronchopneumonia. So, what are the common bacterial pathogens which attack in the case of measles affected individual is staphylococcus, pneumococcus and the gram-negative bacteria. Other respiratory complications what we see is laryngitis, tracheitis, bronchitis, giant cell pneumonia, bronchiectasis and flaring up of the latent mycobacterial tuberculosis infection. So this is most important, like what is flaring up of the latent mycobacterial tuberculosis infection. If the child is suffering from mycobacterial tuberculosis and he had no symptoms, then measles causes flaring up of this mycobacterial tuberculosis infection. And the gastrointestinal complications what we see in the measles is persistent diarrhea, appendicitis, hepatitis and ileocolitis. Another complication, CNS complication what we see is acute encephalitis. It occurs in the measles at frequency of 1 to 2 per 1000 cases. It is most common during the period of rash consequent to the direct invasion of the brain. Post-measles encephalitis, this usually occurs after recovery and is believed to be the immune mechanism. And the most fatal complication what we see in measles is subsclerosing panencephalitis. It usually is seen several years after the infection, after the affected individual has got the infection. And mainly the diagnosis is mainly clinical and it is confirmed by estimating the levels of IgM anti-measles antibody that is present 3 days after the rash and it persists for 1 month. So after the rash appears and it persists for 1 month, these IgM anti-measles antibodies we can get positive in the measles affected individuals. And the DDs. Now the differential diagnosis, it should be differentiated from the other exanthematous illnesses. How we will differentiate is in the rubella, enteroviral and adenoviral infections, the rash will be milder and the fever is less prominent in these cases. And in roseola infantum, usually we have seen that rash appears along with the fever in case of measles, but in roseola, rash appears once fever disappears. And in rickettsial infections, face is paled, which is always involved in case of measles. The starting point of the measles clinical infection is rash behind the ears, but in rickettsial infections face is paled, which is always involved in case of measles. In meningococcemia, upper respiratory tract infections in the pronormal phase which we have seen in the measles are absent in case of meningococcemia, and here the rash rapidly becomes petechial. Drug rashes, they have history of antecedent drug intake. In Kawasaki, along with the maculopapular rash, we have glossitis, cervical adenopathy, fissuring of lips, edema of hands and extreme irritability of the child and scaling, it will be present in case of Kawasaki. So these are the DDs, how we can differentiate measles from other exanthematous illness. Treatment is usually supportive, that is we will give antipyretics, maintenance of hygiene, that is we have to keep the child in the isolated from the appearance of the day of appearance of the rash, and ensuring adequate fluid and caloric intake. Vitamin, in some studies it is believed that vitamin A decreases the morbidity and mortality of the measles. So we start like single oral dose of 50,000 international units in 1 to 6 months of child, and 1 lakh international units from 6 to 12 months of the affected individual, and 2 lakh international units more than 12 months of the child, more than 1 year. And prevention, how we will prevent it? It is by live attenuated vaccine, which in the India the strain used is EZ strain, that is Edmonston Zagreb strain, and the shelf life of this vaccine is 1 year. at 4 to 8 degrees centigrade, and it loses potency rapidly after the reconstitution. So the measles vaccine, it should be reconstituted using sterile precautions, and any unused vaccine should be discarded after 4 to 6 hours, as it may lead to staphylococcal sepsis and toxic shock syndrome. So the dose is 0.5 ml and the route of administration is subcutaneous. Site is right upper arm, usually at insertion of the deltoid or anterolateral thigh. We have two schedules. One is National Immunization Program and the Indian Academy of Pediatrics IAP guidelines. So in the National Immunization Program, usually there are two doses. One is at 9 months and one is at 12 to 15 months. And in IAP schedule, there are three doses. One is at 9 months and then the two doses preferably as MMR at 12 to 15 months and 4 to 6 years. During the outbreaks, what national program suggests is, if the child is more than 6 months, give one dose of measles vaccine and revaccinate mostly 4 weeks later, preferably at 12 to 15 months as MMR. Catch-up vaccination, if the child is less than 12 months, administer the measles vaccine, and if the child is more than 12 months, catch-up is administer MMR vaccine. Adverse reactions we see in case of measles vaccine administration is fever and transient macular rash. So we see measles like illness. If anyone asks, can we see measles like rash even after giving measles vaccine? The answer is yes. We can see the transient macular rash, which is seen usually 5 to 10 days later. Contraindicated in immunocompromised children, that is if the child is having HIV, or if the child is having TB and it is untreated, and if the child is on immunosuppressive therapies, or if the child is having malignancy, in those individuals the vaccine is contraindicated, as it is a live attenuated vaccine, so it is contraindicated. Storage 2 to 8 degrees centigrade. The vaccine is sensitive to both heat and light. It is usually used within 4 to 6 hours of reconstitution, otherwise it may cause bacterial sepsis. And the post-exposure prophylaxis is indicated for all the immunocompromised contacts irrespective of immunization status and the exposed infants aged 6 to 12 months. So usually we don't know about this immunoglobulin status post-exposure prophylaxis, but it is given when the child is immunocompromised contacts irrespective of immunization and exposed infants who are aged between 6 to 12 months. In those children we have to give post-exposure prophylaxis with immunoglobulin. So what is this post-exposure prophylaxis passive immunization is? As I already told, that it is suggested in immunocompromised person or an infant less than 1 year exposed to the infected person less than 6 days back. It is given in the dose of 0.5 ml per kg in the immunocompromised individuals or 0.25 ml per kg in the infant. So that's it, guys. I have completed the first day of illness, that is measles. So if you guys like the content or if you have any queries, please do comment in the comment section, or please like, share and subscribe as much as possible. And if you have any queries, please I will answer them in the comment section, and let me know anything new updates are there. Please subscribe to my channel as fast as possible. Thank you.